Hello, this is Dr. Stephen Mather from the Spine Learning Channel. Today we're going to talk about lumbar fusions, how they were done open long ago, how they're done minimally invasively now, today, and how we went from a posterior open fusion where the fusion rate was essentially 98% down to, depending on what technique you use, a minimally invasive lumbar fusion can be only maybe 60 or 70% successful. And why the fundamentals of the open posterior lumbar interbody fusion got lost along the way, and how you can make sure that your minimally invasive lumbar fusion has the 98% success rate that we saw in days of old. This is Dr. Art Steffi, who basically invented the posterior lumbar interbody fusion. Remember, this is back in the mid-80s. He did this open, and not only would he put in the interbody cages from the back, but he would also do a very generous posterolateral fusion along the spinous processes. This was his basic setup, and you can see the plates that he invented around 1984 in the back. And then he would use in the interbody area this cage, which had large open spaces in it, but there was so much room for bone graft, and he did this open, and he had great access to the whole disc space that it wasn't difficult to create a fusion. This is basically how the cages were put in, and you can see if you put in cages from each side, you had great access to the entire disc space, and even if your interbody fusion didn't do great, it would still heal. About 10 years ago, I presented at the Scoliosis Research Society how you could put in two cages from one side, pack a lot of bone in between the cages, and you could get a very, very solid fusion even without using iliac crest bone graft because the bone was contained between the two cages. So somewhere along the way, someone decided, if we can just put a single cage in and pack a lot of bone around it, maybe we'll get a solid fusion too. So they would put in a single cage and pack a lot of bone around the cage, and they would still do a very hefty posterolateral graft around the transverse processes, and for the most part, it would get a solid fusion. And people came up with all sorts of ideas to put this single cage in. They would use this, what we call a banana cage, and put bone graft all around the cage. And because of their very solid posterolateral fusion and this cage in the interbody space, they generally would get a solid fusion. Then, around 2001 or 2000, someone came up with a great idea. We could put this through a tube. So we'll put all the bone graft and the cage through this tube, through this tiny little incision, and people will love it because we don't have to do all the muscle stripping. So they did. They inserted a cage through the tube, knowing that they didn't have a lot of access around the disc space or a posterolateral fusion. And this is what happened. And for the last 20 years or so, we have seen this happen. A single cage, no posterolateral graft, and the cages don't incorporate. You would start to see some subsidence around the cages and a failed fusion. Now, sometimes they would heal, but a lot of times they wouldn't. And people thought, well, maybe we'll put in a banana cage and pack bone around it that way, and maybe we'll get more support because we can put this longer cage in and sweep it around the front of the cage and pack bone around it. But the same thing happened. We would get a non-union probably 20 to 30% of the time. And here's another version. People would try to use titanium. They thought, well, if PEEK, which is a plastic, doesn't adhere to the bone very well, let's use titanium. Maybe we'll get better. And it didn't. And I asked the specialists all around the country, and they kept saying, you just have to get better at your technique, Steve, and it'll happen. And I would see their technique fail and fail. And then I started to think, look at the XLIF, the direct lateral cage, the big open spaces inside the cage. We would put that cage in with screws in the back, and lo and behold, every fusion would heal. We would use the same type of bone graft. We would use infuse and a little bit of bone DBM, and at 3 months we would see this. This is the second level. This was an old fusion that degenerated the level above. But at 3 months, you can see how solid the fusion was because the bone is all contained inside the cage. And here's a CT scan. You can see that the bone grows right up to the edges and the walls of the windows of the cage. And that's because the bone has to work with Wolff's Law. As the bone is compressed, it's compressed against the walls of the cage, and because it's contained, it will heal. And so I went back to the theory of when I put in the 2 cages from one side, and I packed bone in between, and I remembered how solid the bone was in between the 2 cages, but around the lateral aspect of the cages, the bone didn't look great. So then I tried 2 titanium cages between which I would pack bone graft, and I did this minimally invasively. The technique is extremely demanding and very difficult, and I found that if we used PEEK cages instead of titanium, we could also get a tremendous result. And so about 1.5 years ago, I decided that I started using PEEK cages, 2 PEEK cages, and pack bone in between, all minimally invasively. And the results were amazing. I would see at even 3 months this very solid, mature fusion mass. And the great thing was, on a plain x-ray, and this is an AP view at 3 months, you can see between the 2 cages how solid the bone was. And the patients were doing extremely well. They would not have the residual aches and pains that I would see when I would get a delayed or non-union from a single cage. Now, as difficult as the double titanium cage was to do minimally invasively, the double PEEK cage is markedly easier because it's so much easier to slide the 2 cages across the disc space to do the stack technique or the double cage technique. And you can see this on one of my other videos. So it all goes back to getting the bone packed between the 2 cages. This is a post-op CT scan. The patient had an ileus, so we obtained an abdominal CT, and then we were able to zoom in on the lumbar spine, and you can see between the 2 cages, those 2 white dots are the sides of each cage. I have about 1 centimeter of bone packed between the 2 cages, and that's the key. You get 1 centimeter of bone between the 2 cages, the little bone window in each cage, and this will go on to a solid fusion. Here we are at 5 months post-op from a double PEEK cage done minimally invasively at L4-5. Patient about 20 years ago had an L5-S1 fusion. So I did the MIS TLIF technique, the stack technique, which you can see on one of the other videos at the Spine Learning channel. 5 months post-op using laminectomy bone, a little I factor, and allograft bone. And it's so nice to see on a plain x-ray how solid the fusion is and how solid the bone has matured into, all contained. So as my old professor Jeff Wilbur used to say, so there you have it. So if you want to learn how to do the double cage technique, which I call the stack or sequential transforaminal allograft cage technique, you can see it on the Spine Learning channel here. Look under a revolutionary MIS TLIF technique, because your fusion rate is going to zoom back up to the 98%, even in patients that are using medications such as monoclonal antibodies or prednisone after surgery, the most difficult and challenging patients, even the morbidly obese patients. We've done several morbidly obese patients with this, and they don't fail. So try it. If you have any questions, email me, stephen.mather@dooley.com. I'll be glad to help you out. So long, everybody.